Sorry. And do you want to go back? There you go.
Yeah.
Perfect. All right. Awesome.
Alrighty. Off to the races.
Welcome everybody to our rounds. We're starting a couple minutes late, early today, just because Dr. Neufeld has to leave at 1 o'clock at the absolute latest. He is an
No,
assistant.
at 12:55 at the latest.
Okay, sorry. He is an assistant professor of community psychology at Brock University. He has a PhD in social psychology from Simon Fraser University and has lived in the Niagara region of Ontario with his family since 2021. His research, knowledge mobilization, and organizing work focuses on two key areas. One, developing an understanding of substance use stigma and how it can be addressed that acknowledges the structural, political, historical, and intersectional dimensions of stigma. And two, working towards the equitable empowerment and inclusion of people who use drugs in research, policymaking, and service provision that impacts them. He has been privileged to collaborate with people who use drugs on research and organizing in Vancouver's downtown east side, and more recently, St. Catharines, Ontario, with the Niagara Advocates with Lived and Living Experience. And if we can either put questions in the chat or save them to the end, that would be great. And I will hand it over.
Thanks so much, Kathy. And thanks for the invite. And thanks everybody for being here today online. Yeah, so in the next little bit less than an hour, I'm planning to share a little bit of a perspective that I think is really useful and that's gaining some more traction when people have been increasingly trying to think about how can we address, some of the challenges that face people who use drugs, who are often trying to maybe navigate complex health needs, reduce some of the harms of substance use, and what role we can play when we work within health systems to think about addressing stigma, not only at an individual sort of one-on-one interactional level, but also at a more structural level. So that's where I'm hoping to be going today. A few quick things too. I do not have any conflicts of interest to declare. I know that's important to mention here, but no one's putting me up to this other than Kathy, and she seems legit. So thank you for the invite once again. And just briefly, these were circulated, but the goal is by the end of the talk that we should be able to have a little bit better understanding for different definitions of stigma, self-stigma, public or social stigma, and structural stigma. So we've talked about these at different levels. Understand a bit more how stigma creates harm and worsens health outcomes for people who use drugs. And also discuss different approaches to addressing substance use related stigmas. Well, some that we've really tried and maybe aren't as effective as we hope, and others that have more promise. And finally, that we'll learn a little bit more about implementing different strategies to identify and address structural stigma in healthcare systems, including like your own, in ways that we can ultimately create more inclusion for people who use drugs. I also want to just acknowledge where I'm located here in St. Catharines in the Niagara region at Brock University, where I live and work on the ancestral territories of the Chononton, Mississaugas of the Credit, Anishinaabe, Ojibwe, Chippewa, and Haudenosaunee peoples in the Niagara region. And there's a couple of important treaties here between First Nations groups, including the Dish with One Spoon and two Royal Wampum agreements, and also Upper Canada colonial treaties. And really position myself as a settler, as somebody who experiences a lot of social privilege from different identities, somebody who through my work and activism and organizing is really trying to understand what does it mean for me to sort of be in good relation with other people, especially Indigenous people in these territories, and also be trying to incorporate sort of a health and equities lens in my work, especially around substance use and some of the disproportionate harms that Indigenous communities experience because of structural racism, colonialism, etc. A little bit more about myself too. I'm not somebody who has lived or living experience with criminalized substance use or stigma. In fact, like many of us, the way that I grew up, it was pretty clear that if you were somebody who used drugs, that made you a bad person or a scary person or a dangerous person. And for me to sort of contemplate what would my life turn into if I started using illicit substances, or even in my sort of conservative evangelical Christian community, even alcohol, this clearly, was like a pathway downhill in terms of your social status or value. And where I grew up close to Vancouver, even the downtown east side, that neighborhood that's kind of renowned for concentrations of poverty, of homelessness, of substance use, was really to me sort of a symbol of like social failure in my community. So that's sort of how I grew up, and really very much socialized in stigma towards people who use drugs. Um, but an important part of my story too is that that can change, and I think that can change for all of us. And how that happened for me is that over time, learning more about substance use, getting some more education at university, learning about the injustices of discrimination, especially around people's substance use, but most importantly, becoming friends with and collaborators and learning from people who use drugs themselves, especially as I became a grad student in Vancouver and worked in and around the downtown east side. Just a little bit about that too is that Kathy mentioned my PhD in social psychology, where I really got a lot of training in really the literature and the science of prejudice, of stigma, of how we can address prejudice, stigma, discrimination. And since 2018, I've worked pretty closely with people who would identify themselves as drug user activists, people that live in the downtown east side, people who are active in harm reduction, drug policy researchers, and doing a lot of community-based research, including in collaboration with folks at the BC Centre on Substance Use. And then finally, my actual PhD focus really looked quite intensively at a lot of examples of substance use focused anti-stigma campaigns, which I'm not really going to talk about that work today, but it's sort of the background of how I came to think more about substance use stigma in a more structural way. A little bit of a outline here. We'll spend the first 30 minutes or so mostly me talking, and if you do have questions, feel free to put them in the chat, but maybe somebody can remind me about them later because I'm not actively monitoring the chat myself. But we'll have a bit more time at the end for questions. But a bit of a background on stigma and its connection with toxic drug deaths, including in your health unit. We'll talk about stigma at different levels and some examples of structural stigma. And the big, hope here too is that as we start to think about stigma in different ways, we can really ideally move away from this more individualistic way of thinking about stigma or stigmatizers to what I think is a more useful, impactful, and less, I think, more accessible sort of way of thinking about stigma and how it's something that we can really work on identifying and dismantling together. So if you're coming here and thinking, oh, gee, another stigma thing, I'm going to be made to feel bad, I think the wrong things, it's really not about that today, actually. It's about something else. So I hope you can sort of appreciate that. And then we'll spend a little bit of time. I've got a bit of an exercise. You can ask some questions if you have them, but I'm also going to invite you to sort of apply what I've been talking about and identifying or seeing examples of structural stigma, perhaps within your own organization or community. And I'll hear sort of what people come up with, and then we'll wrap up. Okay. So a little bit of background. You might be familiar with this report. It came out sort of midway through the pandemic in 2021 from the Ontario Drug Policy Research Network, and it identified not only that there's a crisis of people dying from toxic drugs in Ontario, and that this had been exacerbated by the COVID-19 pandemic, but also that there are certain inequities in who is most impacted by people dying from toxic drugs, including people in more northern, sort of and more rural health units of the sort of highest rates of people dying from toxic drugs. In this case, it really pinpointed Sudbury, Porcupine, around Timmins, and Algoma. And I had the chance earlier in this past fall to actually go up to each of those communities and share about this work I'm going to share with you today. So that's sort of one thing that I'll highlight. And just to mention that similar inequities exist in North Bay, Parry Sound. So you can see this is sort of the baseline. These are rates per 100,000 of opioid toxicity deaths over the last couple of years. This is sort of for across the province, and this is what's going on up in the North Bay Parry Sound Health Unit. And this is just data that comes from Public Health Ontario. And so we can really ask ourselves, why? What drives, substance use risks and some of these inequities too? And really, anytime we want to think about what's going on with substance use related harms, there's a few different ways to think about it. On the one hand, there are supply side factors, things that have to do with the supply of illicit drugs. And so one important factor in Canada is that we've criminalized substances. Drugs are illegal, and under prohibition, something that this reliably does, especially over time and as enforcement ramps up, is it often increases the potency of drugs. So we saw in this country a long time ago, our first drug-related laws are about opium, and opium sort of got concentrated into heroin and other sorts of morphine analogs. And then, we had a prescription opioid crisis. And then more recently, we've had a synthetic opioid crisis of illicit fentanyl and analogs, for example. So drugs are deadlier than ever. And that's sort of something that's been really produced by the demands of an illicit market and the sort of, people trying to innovate to avoid, interdiction. And then there's also demand side factors here. Why do people use drugs? There's a few different things here as well. One is that people often use drugs to cope with trauma, whether that's sort of psychological or intergenerational. We've seen that in many, impacted communities or colonized communities. We can think about the impact of stress, something that people use substances to cope with as the pandemic sort of went along, people's mental health and stress levels, got worse, and substance use across the board increased. You can also see people dealing with pain and injury, especially untreated or improperly medicated, work-related pain or injuries. People sometimes transition to the illicit market if they're not able to get their pain needs met with prescription opioids, for example. Also, people often use drugs to deal with adversity. We've seen this in lots of people who identify as people who are homeless or unhoused, often report initiating substance use once they've entered this sort of housing status as a way of coping. For example, people use stimulants to stave off hunger pains, to increase wakefulness, enable them to stay awake all night or avoid, being abused or having their stuff stolen. And there's another factor that I'll just mention, which is stigma. Which is the discrimination, exclusion, the prejudice, stereotypes, the negative treatment that people who use drugs often experience. And this can drive substance use harms as well. So just to back up a tiny bit, there's an old sociologist named Irving Goffman, who actually grew up in Winnipeg. Most of his career was in the United States. But he really kind of famously simply defines stigma as a discrediting mark against a person or a group. And that kind of has two components. One is that it's something that's negative, and two, it marks them as different. So it kind of puts them in a box, something that you can't escape from, negative assumptions about a person. And if we apply that to people who use drugs, it looks a bit like this. This is what happens when we think that a person who uses a substance is marked as a bad person. What do we mean by bad? Somebody that we think endangers or threatens others by their very existence. Somebody who we think is not worthy of care or concern or compassion that we would typically extend to other members of our family or community. Or someone that we assume is untrustworthy or corrupt. And we can really locate stigma at different places within a system. I mentioned this before, but sometimes people talk about different levels of stigma. So if we think about a person who uses drugs in the middle here, kind of, around them, like the walls, the roof of this building, maybe could represent like the policies or the social or cultural norms that we have in our organizations. Things that might be hard to see that are sort of baked into the fabric of the way that we do things or how we treat people who use drugs. We often refer to that as structural stigma. And in here, sort of the air we breathe, the environment, the interactions that we might have with people on a day-to-day basis as somebody uses drugs, when those are sort of caked with prejudice and discrimination, negative stereotypes about people who use drugs, we often refer to that level as public or social stigma. And then in here, sometimes people, understandably, when they're exposed to that, could start to believe or internalize those sort of other experiences of stigma or discrimination, and they might start to come to think negative things about themselves. And we sometimes refer to that as self-stigma. And of course, sort of undergirding all of this is the criminalization of people who use drugs. Drugs are stigmatized because they are illegal. People who use drugs are stigmatized because we categorize them under the law as criminals. And an important other component of this system is power. People who have power are able to stigmatize, dehumanize, control people who use drugs because of their position within society. So it's important to think that, we have this system that impacts people in different ways. How does it impact people who use drugs? Well, if you anticipate that other people will mistreat you because of your substance use, you're often motivated to hide your substance use. And especially if you're using potent and unpredictable opioids, if you experience an overdose while you're alone, while you're hiding, you're more likely to die. It could also be something that sort of encourages people to avoid seeking help by just, I don't want to identify myself as somebody who uses drugs or somebody who's having a problem. So I'm not going to, seek treatment or even access harm reduction because I don't want to experience that stigma that comes from having that part of me revealed. People also just generally experience exclusion, which worsens health outcomes in lots of ways, whether that's from society or from a healthcare organization, as we'll talk about. And then at a more structural or political level, stigma can also function to block or close supportive services that are meant to meet the needs of people who use drugs or increase safety. For example, evidence-based supervised consumption sites or other harm reduction or treatment modalities that we've seen increasingly being challenged or closed in Ontario and elsewhere, in large part because of stigmatizing assumptions about people who use drugs. It's also worth to reflect briefly about what is sort of the role or significance of stigma. As a social psychologist, something that I think is really interesting is to think about how stigma helps us to feel better about inequality, helps us to justify, inequities or hardship that we might observe and feel uncomfortable with in our communities or in our organizations. This is a screenshot from an anti-stigma campaign in Sudbury that I think is interesting. But basically, this woman walks by somebody experiencing an overdose and kind of rolls their eyes and says, "Ugh, those people." But I think stigma operates in a similar way in lots of other contexts, helps us to scapegoat drugs as sort of the primary problem somebody's facing, or helps us to sort of blame the victim and maybe individualize people's substance use. And all of that really works to help us ignore the wider context of structural inequities, things like racism, colonialism, poverty, childhood trauma, all these uncomfortable things that are often really the predictors of people having a hard time with substance use. Helps us to ignore those things and sort of more comfortably sit with the fact that, it's probably their fault. They're to blame. They did this to themselves. Stigma enables that. So what can we do about substance use stigma? Well, I've sort of argued, and I hope you'll sort of follow along here, that there's a lot of different ways people have been trying to do things about substance use, and not all of them are as effective. I sort of think about where does stigma really hurt people who use drugs, and I think that should be the way that we sort of focus our efforts to address it. For a long time, as with many other stigmatized conditions, mental health or HIV/AIDS, we really thought, the main place we need to focus is around people's like public attitudes, the general public think negative things about people who use drugs or they have negative stereotypes. We need to try and address those, and that will be helpful. So we had a lot of anti-stigma campaigns that came out, as my research demonstrated, from about 2017 to 2020. There was hundreds of anti-stigma campaigns that came out across Canada and the United States, all trying to address public attitudes towards people who use drugs. Spoiler alert, they're not super effective and also can be problematic in lots of ways, but I'm not going to get into that part of my research today. At a higher, more structural level, for a while there, people were pretty excited about decriminalization as an approach to a more structural way of addressing stigma. So we saw a pilot project on this in British Columbia and people agitating for this in other places, including Toronto. And a big focus of this was to address stigma. As it turns out, though, that was a pretty challenging to do politically and didn't last very long in a sort of fragile political, context that we're in, where there's a lot of backlash to harm reduction efforts, for example, and kind of a resurgence of public and politicized stigma towards people who use drugs. There was also always sort of questions about how exactly would decriminalization sort of trickle down to tangible changes in people's experience of stigma and exclusion. And some of my students and I have sort of looked at that critically and wondered, To what extent was that actually going to work? But there's another level at which we can try and address stigma. And I'd actually argue that it's here within our organizations where people who use drugs try to get their needs met and are often met with exclusion or discrimination or mistreatment. That's actually potentially where stigma both matters the most in terms of how it really creates harm for people in a deadly way, and also is the most changeable. It's very challenging to change individual people's public attitudes. It's been challenging to decriminalize drugs. But I think here is where we actually have the most possibility for change and also where we have the most possibility for real impact. Just to sort of offer a brief definition, because we're going to be mostly talking about structural stigma from here on. This is how the Government of Canada identifies or defines it. And there's some decent parts of the definition here. There's a few examples. They say policies in health and social services that increase stigma, like not providing services until drug use is better managed, so more punitive policies. How kind of negative attitudes are embedded with healthcare providers or first responders, workplace policies that might encourage people to hide drug use, like unnecessary drug tests or surveillance at a structural level, and just generally low quality of care for people who use drugs when they're trying to access health services. Now, I kind of tell my students sometimes the only time you should really cite the government's definition of anything is if you want to critique it, but this is not terrible. These are some more academic definitions, including from my friend Jamie Livingston, who says rules, policies, procedures of social institutions that arbitrarily restrict the rights and opportunities of people who use drugs. And this is my friend Ben and myself and some colleagues published a paper a couple of years ago on decriminalization and stigma. We called it the systematic devaluation of people who use drugs through policies that reflect and facilitate their social exclusion. I think it's sometimes easy to summarize these things with fun diagrams. So we'll do this approach for a bit. In any kind of organizational context, you could think about your own health center up there in West Parry Sound. We've got people who use drugs who want to feel included. They want to receive compassion. They want to have their needs met. But how we treat them as staff, as care providers, how we treat people who use drugs as individuals can sometimes be influenced by prejudice, by stigma, by negative attitudes. And that can create a feeling of exclusion and worsen the care outcomes for people who use drugs. But there's also another thing. There's the structure of our organizations, which could do this too, the policies that we have, even the built environment of our organizations. So if we sort of build on that distinction a little bit between the structure, the policies, the built environment of our organizations, and the staff, the people who work in it, we could think about interventions here too. On the one hand, sure, there might be things that we can examine around people's level of compassion for people who use drugs. How do you respond to them emotionally? What do you think about them? Is that really negative? Is that rooted in negative stereotypes? But there also might be just a dimension of competency here, which is that sometimes we're not able to really provide very good care for people if we really don't feel comfortable or competent in knowing much about substance use or about addiction or, about what's actually going on for a person. Sometimes it's just been something that hasn't been reflected in our training. That might actually be a component of it. So how can we address that? Well, there could be room for additional professional development or education. And there also could be some room for, hearing from people with lived experience or trying to learn more or adjust our attitudes or our approach or response to people who use drugs. Now, at the structural level, there's sort of two things here. One is that organizations often have fairly inclusive ideals. We might have sort of like a statement of our, aspirations around what the kind of healthcare organization we want to be. We're going to be, are committed to reconciliation and inclusion and equity and all these things. We sometimes make these grand statements, which could be good. That could be one way of saying, okay, good. Yeah, we're on the right track there. But there's also all the way down through all of our organizations, a bunch of micro policies that make up the day-to-day operating procedures of how we do things in our hospital, in our clinic, in our methadone clinic, in our treatment center. And those could be baked, sort of rooted in stigmatizing assumptions too. And I kind of argue for this metaphor of what I call structural integrity, which is that keeping with this theme of like a building or organization or structure, so that ideally we have a sort of alignment between the inclusive ideals that we often share as an organization around the kind of healthcare we want to provide and what we actually do. in terms of how do we actually interact with people on a day-to-day basis, what's laid out in our standard operating procedures. I also want to point out that these two levels of stigma or sort of policies actually shape each other. And I'll give you a couple of examples. So if we've got staff here and structures over here, anytime that we've got, some kind of a set of policies or a hospital that we've built, well, somebody built that, right? People, and to what extent they thought certain things about people who use drugs, that probably shapes the things that we build. And at the same time, when we operate under the sort of domain of a structure, of policies or something, our structures often shape what we then think, for example, about people who use drugs. So sort of to illustrate, if if we started from the assumption that people who use drugs are dangerous, well, that might shape, the way that we design how people access care. For example, maybe in a clinic or a space where we know that we're often interacting with this population, we've put up, protective shields to really create barriers between our staff and, our clientele that we've sort of constructed as dangerous. And at the same time, if somebody is maybe new to our organization, maybe they didn't necessarily come with this assumption, when they see those protective shields and they sort of grasp what they're there for, well, they're there to protect me from our clients, that might lead us to the conclusion, well, people, must be dangerous if we're protecting ourselves from them in this way. That's just one example. There's lots of other ways that there's this sort of interaction between these different levels. Um, and sort of the structural policies, the environments, the culture of our organizations also sometimes might no longer reflect what we actually believe about addiction or the status of people who use drugs. So it's entirely possible that we might have policies in place that if we really scrutinize them, if we put on our structural stigma sort of goggles, as I'll mention in a moment, we might see, wait a second, somebody developed this policy about how you've got to be abstinent from substances for 5 days before we'll even help you. Who came up with that? We might not actually think the same things that they did when they put that policy in place, because that policy is rooted in the idea that we need to punish people, that we need to, make them prove themselves or prove themselves that they're worthy or that they really care or they really want it. That might not actually reflect an up-to-date evidence-based understanding of addiction. And might not reflect a modern sort of current compassionate approach to people who use drugs who are experiencing serious risks to their health and life. So that is a thing that can happen in our organizations too. And you could even think about this as stigma being an inheritance, something that might be just kind of lurking in the corners of our policies or built environments in our organizations. But there's good news here. Oops. Oh, this was the thing that I just wanted to say, which is that it's entirely possible for there to be people that have all of the love in their hearts and compassion individually for people who use drugs, yet nevertheless be operating under policies or standard operating procedures or built environments that are rooted in structural stigma. It's entirely possible for those two things to coexist. And unless we really turn our lens towards identifying and dismantling those, we might never see them. But the good news, as I was going to say, is that we can unlearn what we've learned about people who use drugs and substance use when that's rooted in stigma. And we can also rebuild structures that are rooted in stigma. So I really want to argue that this sort of lens of structural stigma can help us to see those cracks in the foundation. It can really help us think, how has stigma towards people who use drugs been encoded into the culture, the policies, the assumptions, the built environments of our organizations? Really to think about that in a systematic way through every level of how we interact with people who use drugs. And the good news too is that there are actually tools that can help us to do this. So I've used this metaphor already, but kind of fun to illustrate it this way. We can put on sort of like structural stigma goggles that are going to help us to pay attention in a different way, take a new lens to look at our organizations with, which could include things like identifying organizational policies or challenges with staff competency or individual attitudes, and also hopefully getting feedback from people who use drugs who use our services on their experiences so that we can learn where are the gaps, where are the limitations, where do people commonly experience exclusion or marking or feel disrespected or left out. This is one example of a tool that was developed in 2023 by the Canadian Public Health Association. It's really just a series of questions and a process that you can read through and apply to any organization. And it's meant to help you really think systematically, almost like an audit, about identifying and dismantling structural stigma as it affects people who use drugs. Another nice thing about this tool is that it was developed in collaboration with CAPSA, which is folks with lived and living experience of substance use based in Ottawa. So it's a really pretty useful tool. I also want to just note that this is something that most organizations are doing already. We often call it quality improvement, that we generally care about the experience that our clients or patients are having in our healthcare settings. Quality improvement departments are often, tasked with assessing and really figuring out how can we improve things, how can we make things better. Reducing stigma, identifying, dismantling structural stigma is an example of quality improvement. It's something that we already do, that we're already often committed to as organizations. How do these work? They're really about just taking that lens and really looking systematically for examples of structural stigma in our organization. Really think about how do the features of our system mark people as different and bad? How could our system policies and practices be reoriented to create wider inclusion for people who use drugs? So that can involve looking at things like what are our policies? What are our procedures? What's the culture of our organization? What's the built environment of our organization? Could be reviewing things like what training or competency level do service providers who work with people who use drugs have. Can be about really going to people who use drugs, service users, and saying, what makes you feel comfortable or uncomfortable within our organization? How could we change that? And also help us to really think more about, are we listening to people? Do we have some mechanism that exists for people to let us know when they have concerns about how they've been treated? Do we listen to that? Do we take that seriously? It's really going to help us to really think through, do policies at every level align with those more aspirational organizational values or inclusion statements? I'm going to pick on Sudbury for a moment, but this comes from their public health, Sudbury and districts, the PHSD, their public health unit up there. For example, this is on their website. They say, we are a progressive public health agency committed to improving health and reducing social inequities in health through evidence-informed practice. Fantastic. Are you actually doing that at every level of places where people interact with your services? That's sort of the big question. And I argue that's sort of this idea of structural integrity, that ultimately the goal is to get those things to align so that we can remove all those sort of ways that stigma has been baked into the fabric of our organizations. Another approach that we might take in assessments like this is really adopting the perspective of a client. We can think about things like, how do people learn about our organization? How do they, get to us? Is there accessible transit? Are we, way out in the middle of nowhere? What's it like to enter our building? What are their subtle cues that are going to let people know whether they're welcome here or whether maybe, we kind of wish that you didn't show up? And how are people going to feel when they're sitting in our waiting room? All of these are good ways that we can start to think about how is exclusion or inclusion sort of constructed for people at that structural level within our organizations. There's a nice example from that CPHA document where they say, if you primarily, serve the needs of people who are experiencing poverty or homelessness, do you have magazines like this in your waiting room? How is that going to make people feel whether or not they belong here? We can also think really about how do the systems that we operate in, this comes from a sociologist in the UK, Imogen Tyler, how do they sort of function as machinery designed to identify, mark, exclude, and control people? So we can think about lots of ways that our health systems often work to mark people, to surveil people who use drugs, identify, control, or exclude people who use drugs. Here's just a few quick examples. Oftentimes people report when they try and access care in a hospital and an emergency room setting for various reasons, often related to stereotypes about race or class. They might feel like they've been flagged as drug seeking. And this starts to be the lens through which all of their concerns or complaints related to their health are interpreted by healthcare staff. Sometimes people's charts might include marks or indications about their substance use in, prior presentation as intoxicated, or even the use of, things like methadone that may stay on a client's charts for years and years and continue to just sort of be that moment in their care experience where all of a sudden, oh, or this kind of person. Oh, here's a detail about you. That might change the way that we interact with somebody just based on what we've seen in their chart. It's another example how people have marks put on them that really flag them as somebody that maybe we should treat them differently. Maybe we should stereotype them. Maybe we should treat them as if we know a lot about their situation without asking about them. Maybe we should mistrust them. Another good example of how stigma has been baked into different healthcare systems is prescription drug monitoring programs that, were introduced as a sort of reactive measure in the panic of the prescription drug, overprescribing crisis, but really functioned as a way of identifying people who were having a problem with their substance use so that we could kick them out. And many people, when they sort of, fell on the wrong side of PDMPs, it's been documented, were sort of identified, stigmatized, and excluded, and often then transitioned to the illicit market, where they experience much worse and more significant and unpredictable health-related harms. We might also see this in abstinence-only or punishment-oriented policies for people who use drugs who are trying to seek care. For example, I've encountered lots of people who maybe are having a problem with, some kind of really serious illicit substance, and they'd be interested in accessing addiction treatment. But many of the options available to them include sort of unnecessary, sometimes arbitrary, restrictive measures. For example, no smoking. Well, I don't know if I can give up, opioids at the same time as I can give up smoking. Is there no way that we could create more inclusion or meet people where they're at here? What are the implications of systems like this that mark people who use drugs as different and bad? Just from a purely social psychological level, when we categorize people as us, as us and them, that just generally reduces our likelihood of feeling like there's somebody that, is like us, that we want to help. This can also just be a basis for activating those negative stereotypes, even unconsciously. And when we mark people as different and bad, that kind of stigma can also often help us justify policies of exclusion. And just generally, we're going to be less likely to meet people's actual needs. This can result in sort of just reduced access for people who use drugs to healthcare, reduced quality of care that they experience if they do manage to access care, and this thing called diagnostic overshadowing. It's a bit of a fancy term, but it just refers to when somebody's presenting and we identify them as somebody who is currently or formerly had a problem with substance use, we sort of treat that as the main thing and almost blinds us to the thing that they're actually telling us. They might be presenting with, a broken arm and a bone sticking out, but we say, I kind of think they're just here for drugs. Maybe you should just go home. It's a bit of an exaggeration, but it's things like that. People experience that all the time. It can be devastating for people to the extent that sometimes it's not uncommon for people who use drugs with serious healthcare issues, serious wounds, serious things that require emergency medical attention to say, I am not going to that hospital. I would rather die than be treated the way that they've treated me in the past. That's really one of the most deadly implications of stigma in these organizations that are ideally set up to meet people's needs and address people's healthcare needs. So to sort of sum up here, how do we address structural stigma? Well, I hope that these tools and thinking, organizational assessments, that kind of systematic thinking through, to me, that's a really promising approach. I hope you won't think maybe we should do more anti-stigma campaigns. I really kind of just want to emphasize, I spent a lot of time looking at anti-stigma campaigns, including the research on their efficacy, and it's really not very compelling. And even you can probably see that if you just think about it for a moment. This is a fairly common approach. We put some kind of a compelling poster up on a bus stop or something. And I call this sort of a bus stop theory of stigma change, which is the assumption here. How's this supposed to work? Well, I'm assuming people are going to look at it. They're going to read it. They're going to think about it. And they might change something. Maybe they're, deeply socialized attitudes about people who use drugs. Maybe. And then they're going to take some action that's going to have some meaningful impact, positive impact in the lives of people who use drugs. I'm really not so sure that ever happens. And even if it did, this sort of random dude here waiting for the bus, most of the time probably has zero impact on the life chances of people who use drugs. So I think it's really looking in kind of the wrong place. It's got an ineffective mechanism or theory of stigma change. So I hope you can sort of at least take away from this that we should hopefully be moving away from this more individual level of trying to address stigma one-on-one to something more structural, almost thinking about how can we put a wrench in the machinery of stigma that produces the exclusion, the marking, the dehumanization of people who use drugs. And who should be involved in this? Well, I think, oops, I included the PHSD, but I should have put WSPHC. Everyone should be involved in this work, even if somebody doesn't work directly in the substance use field. This should include all levels of leadership, managers, frontline staff should really be thinking about this perspective of how we can address structural stigma. And most importantly, perhaps, putting people with lived and living experience of substance use stigma right at the center. It's just sort of a no-brainer once you start to think about it, that people use drugs, people who use our services, who've experienced exclusion, have the most valuable perspective. If we're interested, honestly, in identifying how and where have our organizations, our policies, our practices, our attitudes, our competencies created exclusion and harm for people who use drugs when they've tried to get their needs met. One last point is just to sort of drive home the value of self-reflection for each of us, even for myself, which is that stigma, even if we're talking about it as a structural level, is not just out there somewhere. Sometimes we can talk about stigma structurally and almost conclude, well, does anybody actually, think in stigmatizing ways? We do, absolutely we do. So we need to reflect not only on how our systems have stigma baked in, but also how ourselves might have stigma baked in based on how we've been socialized. To quote my friend Taylor here, it could be us who is sort of the problem. We need to reflect on that too. Briefly, some questions to sort of leave here today, and we'll do a little exercise after this. Really think about what is the shape of the stigma system that targets people in our context? How could we work collaboratively in partnership with people who use drugs to better understand and dismantle this system? And what would effective stigma disruption feel like for people who are the worst affected? So thanks very much. And I want you to sort of invite you to try this out for a minute or two here, kind of to put your structural stigma goggles on for your own organization or community, and really sort of think, let's see here, even if we just took like a minute or a few minutes, you want to just write down an idea. You can put it in the chat if you like. One or two potential examples, maybe some ideas have been percolating already of structural stigma that really impact people who use drugs, that create exclusion. Could be in your organization, could be in another one. Just want you to think about that for a moment, and then we'll have a time to hear from you, and also you can ask general questions if you'd like. We'll give you another minute to do that. Actually, let me see. I don't know if anybody's put anything in the chat there. Oh, there's an AI person in the chat. Nice. So feel free to write something into the chat. And if not, I'll invite anybody, if you have an idea or an example, or even just a general question, if you want to share that now. We've got about 15 minutes before I need to head out. But I'm very eager to hear sort of people's responses or reflections, and especially, yeah, so Becky's just put in here, being denied pain medication because somebody's been flagged as drug seeking when they've got, two broken arms. This is a fantastic example, and it's something that many people experience, and it may depend on who the person is or how they're presenting or what their history is. And I don't know, your husband's specific story, but this is a really common experience where people really experience a really serious sort of a feeling of a lack of respect, lack of being treated seriously. and really being dehumanized and sort of undignified when they're trying to get their needs met. They're trying to manage their pain, but just being flagged as somebody who doesn't deserve it by the healthcare system is an example of structural stigma. It's a great example. Anybody else? And feel free to just ask sort of general questions if you'd like as well.
Hi.
Hi.
One of my thoughts around this was, and I haven't tried to access it very recently, but it used to be really hard for us to access Suboxone in the emergency department. But
Yeah.
it's in fact, throughout the hospital and for a while, it was actually easier for the unit coordinator to run across to the local community pharmacy than to actually call the pharmacist or somebody to unlock that like very special area where Suboxone was kept in the hospital. But I mean, obviously we have like a lot of hydromorphone and fentanyl available to us. So that was just one thought. I had another thought though about like flagging and things like that. And it's from multiple angles because I've worked in the emergency department, I work in lifestyle medicine, I've done some work with the REM clinic. So I think I understand many different aspects of this, but there's also it's actually dangerous to work in the emergency department. I have at least two of my colleagues that have been punched in the face, one of which could not return to her regular work for at least 10 or 12 months because she was quite concussed after being assaulted. And those are physicians. I'm sure it's even worse for nurse. I'm really sorry for that because they interact so closely. And it's hard because on one end, of course, people can change, people can have a second life, and people have different situations. And it's true that like at some point they will be in pain, and it will be because they have appendicitis or whatever. And the violence, like sometimes, just because one time they were intoxicated and violent doesn't mean that for the rest of their lives, every time they're going to present, they're going to be intoxicated and violent. And it's really hard for me to wrestle with the like protecting the team and not stigmatizing. I obviously don't have an answer for this. Like it's just a reflection that I was having of
Absolutely.
how
And
do
I'm
we
glad you mentioned
actually.
that. Yeah, I'm glad
Yeah.
you mentioned that. And I absolutely agree. That is an important tension. And it isn't to say, that we should, prioritize that every single patient, every time they present has like a carte blanche and we have no right to know anything about their past history and no right to like protect workers from violence, for example. I'm not saying that. But what I am saying though, is just sort of to point out, as many people have, that, I think sort of the default position is to really kind of lean towards the identification, the marking, the sort of the assumption that past behavior will always predict future behavior, and that has really negative repercussions for clients as well. And I think it's just to name it as attention, as something that we maybe should wrestle with more than we do. Whereas the default assumption is, no, of course, we need to just sort of prioritize being able to know everything that we possibly can about a patient and take actions based on that information, regardless of how they're presenting today. And I think that is at least something that we should maybe, as much as we can, begin to question. What are all of the dimensions of that? How long does that stay on somebody's chart? What do we do with that when we see that? Are there other approaches that we can take here that sort of meet somewhere in the middle between protecting worker safety and also giving folks a chance to get their needs met and not to be stigmatized and excluded based on whatever's showing up in their chart. But I agree with you that I'm glad that you mentioned that it's an important tension. But I think the main point is that it is a tension, and mostly it's not. Mostly it's sort of treated as, well, of course we need that information.
Thank you.
Anybody else? Or other examples that people were able to identify?
I was going to suggest maybe forgetting the fact that not everybody carries a cell phone or has
Mhm.
access to a phone in general.
Yeah. In what context?
I'm thinking the homeless person.
But is there a situation where that is an assumption in your healthcare system?
I think so, for some of our homeless people.
Right. So, yeah, assumptions about how we might be able to follow up with people, what it means if we're unable to communicate with somebody or if they don't meet follow-up appointments. Often when we're dealing with members of a stigmatized group, our assumptions and interpretations and attributions shift towards more negative ones. Well, it's because they don't care, because they, are irresponsible. It's because they are lazy. It's because they, don't prioritize their own health or well-being, and then we sort of shift towards this victim blaming thing when often there's perhaps a more structural, like sympathetic explanation for somebody's behavior that we might have gravitated towards if it was a different kind of person from, often a group or identity that's more similar to ours. We might say, oh, maybe they don't have a phone, maybe their phone broke, or maybe they're, dealing with a lot right now. So that's, yeah, a good example of how our assumptions about what resources do people have access to, what's their actual situation in life, are one, something that we need to inquire about and really understand as we're trying to meet people's needs. And two, is something that maybe we shouldn't make, the kinds of assumptions that we often do about. Anybody else? And feel free to sort of, if you had more general questions beyond this activity, feel free to add those into either the chat or just to follow up verbally.
More just a comment than anything.
Yeah.
It's just about the being a smaller hospital in a rural setting where a lot
Yeah.
of the care is with family doctors and that kind of thing, as generalists.
Mm-hmm.
It's hard to be an expert in every area, and how that can be challenging, because for something that would be life threatening to people in their 20s, 30s, and 40s, if it was another issue, I would have better follow up. If it was a cancer related issue, they'd have an oncologist. If it was a cardiac related issue, they'd have a cardiologist, they'd have this input. But it can be hard to get access. The wait times are long for drug services, and it's time consuming when you're rounding and dealing with their osteomyelitis or whatever complication, and then the drug addiction too. And I think that can create some burnout, and that can really cause um, some of the stigma too.
Yeah, no, that's a good point too. And I think the wider working conditions and people's like subjective psychological experience of their work is another important component when we think about what are the things that potentially work to produce like negative care experiences for people from stigmatized groups. There's actually a really interesting intervention and study that was done, I believe, in BC by some folks from the Mental Health Commission of Canada, Stephanie Knack and others. And they did an intervention with service providers, healthcare providers who work with people who use drugs, people experiencing addiction and substance use related harms. And the intervention was not really about education around stigma primarily. It was about identifying sort of strategies for, I guess you could say, sort of like better being able to manage work-related stress. And they found that their intervention, which had a positive impact on people's sort of subjective experience of their work, their ability to, feel better about their work or feel less burnt out, these kinds of things. And that actually had a downstream positive impact on, their sort of like endorsement of stigmatizing ideas or generally their care of people who use drugs. So I think it's a really important component that we sometimes ignore. I think it's really easy in conversations about stigma in healthcare to really sort of blame, healthcare providers who are working in really difficult, stressful, like you said, work environments where, especially in rural communities and smaller hospitals, you don't have as many resources. You may not be have access to as many, specialized forms of expertise. And that can be really frustrating. And that it makes sense that people maybe aren't always at their best, or are responding with the most sort of compassion or competency to folks who are often absolutely difficult to work with. People that are presenting as intoxicated or presenting with a lot of the complications of comorbid mental health and substance use, and whatever else is going on for them. That's not a challenge. That's not an easy population to work with on our best days. And in healthcare, as you all know, it's our best days are sometimes few and far between because of the system and the structure that we work within. So it's just to say that interventions to ideally, improve care at a more structural level might include adjustments to whatever possible, work environment, access to resources, competency, like training. These kinds of upstream things can have really positive impacts downstream in terms of the care interaction. But I'm glad you mentioned that as well. Anybody else? Kathy, I forgot to add a slide about it, but I know that there's, I don't want to wrap things up prematurely here, but I know there's some kind of a evaluation component or something that people are directed to at the end of this.
Yeah, I actually send out a survey link.
All right. Great. Well, if folks, when they get a chance, if you don't mind filling out the survey, it's always helpful to get feedback on things. And if there are not any other questions for me right now, I do invite you to send me an email if you're interested in further conversation or access to resources, some of the things that I've talked about. Happy to share the organizational assessment tool from the Canadian Public Health Association or anything else that would be of interest. Anything else, Kathy?
No, I think that was it. Thank you so
Great.
much for coming and presenting virtually to
Yeah.
our team. And yeah, so I know, well, I learned from you on the weekend and I'm learning from you even more today.
Great. Yes. Thanks. I'm really intrigued by this little AI thing that is summarizing the takeaways. I'm going to go check out the full summary here. Great. Okay.
Oh,
Well, thanks so much, folks. And if it's all right, Kathy, is it okay if we say goodbye?
I don't see anyone else popping up, so I think we're
Okay.
good. Thank you so
Great.
much. And yeah, take
Thanks,
care.
everyone. Have a good rest of the day. Bye.